Hello, this is Dr. Michael Pedersen. I'm the Director of Echocardiography at the Children's Hospital of Michigan and Wayne State University. Over the course of this talk, I'll be covering the echocardiographic evaluation of atrioventricular septal defects. As a general background, AV septal defects account for approximately 3 to 5% of congenital heart disease. There's an approximately equal male to female distribution. As you know, there's a very high incidence of this defect in patients with trisomy 21 or Down syndrome. Of these patients with trisomy 21, approximately 40% of these have congenital heart disease. And of these with congenital heart disease, approximately 40% have some form of atrioventricular septal defect, most commonly a complete AV canal defect. Conversely, about 50 to 60% of all patients with AV septal defects have trisomy 21. This spectrum of defects is also relatively common in the asplenius syndrome, also known as right atrial isomerism, and occasionally in the polysplenius syndrome, also known as left atrial isomerism. In terms of the embryology of AV septal defects, this is due to incomplete septation of the embryonic AV canal by the endocardial cushions. This defect results in a spectrum of defects that involves the primum portion of the atrial septum, the inlet portion of the ventricular septum, the atrioventricular valves, the left ventricular outflow tract, as well as displacement of conduction tissue, which gives the characteristic left axis deviation that we see on an electrocardiogram. An important component of evaluating the anatomy of AV septal defects is evaluation of the atrioventricular valve morphology. In the setting of a complete AV septal defect, there's a common atrioventricular valve that contains an anterior and posterior bridging leaflets, left and right lateral leaflets, and a right accessory leaflet. With a partial AV septal defect, there's partial fusion of the anterior and posterior bridging leaflets, and this will result in a two-orifice valve with a cleft in the left atrioventricular valve. In this spectrum of defects, there's also abnormal position of the left ventricular papillary muscles with a counterclockwise rotation of the position of the papillary muscles relative to a normal heart. This slide depicts the typical anatomy of the atrioventricular valve in AV septal defects. In the top illustration is the typical valve morphology in a complete AV septal defect. We can see the anterior and posterior bridging leaflets, the right and left lateral or mural leaflets, and the anterosuperior leaflet. The bottom diagram shows the typical anatomy of a patient with a partial AV septal defect. In this case, there's fusion between the anterior and posterior bridging leaflet, so there's a connecting tongue between these two leaflets. Invariably in this setting, there's a cleft in the anterior leaflet of the mitral valve. This pathological specimen shows this anatomy in a cross-section of a heart with a complete AV septal defect. As we saw with the diagram, we can see the typical 5-leaflet common atrioventricular valve with the anterior and posterior bridging leaflets, the right and left lateral leaflets, and the anterosuperior leaflet. Assessment of the atrioventricular valve morphology is especially important clinically because of the predisposition of these valves for regurgitation. Frequently, this involves the cleft in the left atrioventricular valve, which is the commissure between the left halves of the anterior and posterior bridging leaflets. This cleft points towards the inlet septum. This can be compared to hearts that have an isolated anterior mitral valve cleft, in which case, in the setting of an isolated cleft, the cleft usually points towards the left ventricular outflow tract. There can also be the presence of a small left lateral leaflet that can also predispose to regurgitation. In this setting, there's often a left ventricle to right atrial shunt. One anatomic form of the valve that can be present is a double orifice left AV valve, and this can be present in approximately 5% of cases. In general, the combined effective opening is always less than the opening of an otherwise normal valve, and these valves do have a higher incidence of regurgitation after repair. In AV septal defects, you can also see a single papillary muscle, the so-called parachute mitral valve, and very often these valves do have a predisposition to both mitral valve stenosis and insufficiency. The morphology of the common AV valve has been subclassified based on the amount of bridging and chordal attachments of the anterior bridging leaflet, and this is the Rastelli classification. In a type A Rastelli common AV valve, there's minimal bridging of the anterior bridging leaflet with chordal attachments to the crest of the ventricular septum. In a type B Rastelli valve, there's more bridging with chordal attachments of the anterior bridging leaflet into the body of the right ventricle. With a type C Rastelli valve, there's a maximal amount of bridging. This is the so-called free-floating anterior leaflet with chordal attachments to the right ventricular free wall. There can also be straddling of AV valve chordal tissue into the opposite ventricle, and this is important to define because this can affect the ability to septate these ventricles. On this slide, again, we're seeing the pathologic specimen of the common atrioventricular valve. In this case, we can see that the anterior bridging leaflet is inserting onto the crest of the anterior portion of the ventricular septum, making this a Rastelli type A valve. This is an illustration showing that same valve morphology with Rastelli type A and the anterior bridging leaflet inserting onto the crest of the ventricular septum. In this slide, we see that there's a greater degree of bridging of the anterior bridging leaflet over into the body of the right ventricle, and in this case, there will be chordal attachments into the body of the right ventricle. This slide demonstrates a Rastelli type C valve. This is the so-called free-floating anterior bridging leaflet, which spans from the free wall of the left ventricle all the way over to the free wall of the right ventricle. An important aspect of the anatomy of atrioventricular septal defects is the anatomic potential for intracardiac shunting. In the setting of a partial AV septal defect, the AV valves are adherent to the crest of the ventricular septum, allowing only shunting at the atrial level. With a complete atrioventricular septal defect, the AV valve is free-floating within the septal defect, and in this case, shunting can be allowed at both the atrial and ventricular levels. A transitional AV septal defect is a case in which there's incomplete attachments of the AV valves or chordae to the ventricular septum, in this case resulting in restricted left-to-right ventricular shunting. Evaluation of the left ventricular outflow tract is important in the assessment of AV septal defects. There's a deficiency of the inlet ventricular septum leading to an inlet-outlet disproportion within the left ventricle. There's also an anterior unwedged position of the aorta. This has been referred to as the sprung aorta. This combination of factors leads to the classic gooseneck deformity of the left ventricular outflow tract that can be seen by echocardiogram or angiogram. And all of these factors, along with the presence of accessory AV valve tissue, can cause or contribute to the presence of left ventricular outflow tract obstruction, and assessment of this by echocardiography will be important. The illustration on the left-hand side of this slide demonstrates the inlet-outlet proportions of a normal left ventricle. In this case, we can see that these two distances are relatively equal. The illustration on the right-hand side of the slide shows the inlet-outlet disproportion. The deficiency of the inlet portion of the ventricular septum, as well as the anterior displacement of the left ventricular outflow tract, results in this disproportion and is one of the factors that can cause or contribute to left ventricular outflow tract obstruction. The associated defects that are most commonly associated with AV septal defects include left ventricular outflow tract obstruction, patent ductus arteriosus, ventricular hypoplasia of either ventricle, coarctation of the aorta, double orifice mitral valve, additional muscular VSDs. Tetralogy of Fallot can be seen, most commonly in the setting of patients with trisomy 21, and more complex anatomy including double outlet right ventricle, total anomalous pulmonary venous return, and pulmonary atresia, with many of these more complex hearts being seen in the heterotaxy syndromes, especially the asplenius syndrome. The physiology of these defects depends on which components of the AV septal defect are present. In the setting of a partial AV canal, there's the presence of a primum atrial septal defect, but no ventricular septal defect. In this case, the physiology is very similar to an isolated atrial septal defect. with significant right-sided volume overload. In the complete form of AV septal defect, there's both an atrial and ventricular shunt, resulting in marked volume and pressure overload. In both of these cases, atrioventricular valve regurgitation may exacerbate the volume overload and symptoms of heart failure. In terms of the clinical manifestations of a patient with a partial AV septal defect, these patients most often present on the basis of an asymptomatic cardiac murmur. Rarely, tachypnea and poor weight gain may occur, and these symptoms are somewhat more likely in these patients than in patients with an isolated secundum atrial septal defect. Significant mitral insufficiency or left ventricular outflow tract obstruction may exacerbate these symptoms and lead to earlier presentation of these patients. In terms of the natural history, untreated, these defects can lead to right ventricular failure, atrial arrhythmias, stroke, and pulmonary vascular disease, with these findings becoming increasingly common into adulthood. In patients with complete AV septal defect, the clinical presentation is similar to that of an isolated large VSD. Tachypnea and failure to thrive occur early in infancy due to excessive pulmonary blood flow. Untreated, pulmonary vascular obstructive disease develops, resulting in shunt reversal and cyanosis, also known as Eisenmenger's complex. In terms of surgical intervention, partial AV septal defects are typically electively repaired at around age 3 to 5 years. If the patient has significant complicating features, including significant AV valve regurgitation or significant left ventricular outflow tract obstruction, earlier surgical intervention may be necessary. In patients with complete AV septal defect, these are typically electively repaired by 6 months of age, and possibly earlier in patients with trisomy 21 to prevent the development of pulmonary vascular obstructive disease. In patients with unbalanced AV septal defect, two-ventricle repair may not be possible, and these patients may require pulmonary artery banding as an initial operation, followed by staged single ventricle palliation leading to a Fontan operation. In the current era, operative mortality is low for this spectrum of defects with good long-term outcomes. The most common cause for reoperation is for mitral regurgitation, and this occurs in approximately 10 to 15% of patients after repair of partial AV septal defect, and in 15 to 20% of patients after repair of complete AV septal defect. Patients in whom the mitral valve cleft was not closed have the highest rate of reoperation for mitral valve repair. It is also possible for all of these defects to develop progressive left ventricular outflow tract obstruction, and this may also necessitate reoperation. Residual shunts are a relatively rare cause for late reoperation. Next, I will go through the standard echocardiographic windows with an emphasis on the important anatomic and functional features of AV septal defects, starting with the peristernal long axis view. One of the first things that can be noted in this view is the abnormal orientation of the mitral valve. In the normal heart, the tips of the mitral valve leaflets are typically pointed towards the apex of the left ventricle. In many patients with AV septal defect, these leaflets often point more towards the ventricular septum. The peristernal long axis view is good for looking at abnormalities of the left ventricular outflow tract, and this can include the presence of accessory chordal tissue and possibly the presence of discrete membranous obstruction. With this view, color flow assessment is important for the assessment of regurgitation of the left atrioventricular valve. The peristernal short axis view is a good view for evaluating the relative sizes of the two ventricles. This view can be used to look at the number and location of the papillary muscles. As you can see in the illustration, the orientation of the left ventricular papillary muscles are in a more counterclockwise orientation than those in a normal heart. In this view, the cleft can be visualized in the anterior leaflet of the mitral valve. In this view, with scanning in the region of the inlet ventricular septum, the inlet VSD can be appreciated, and with scanning more towards the apex, additional muscular VSDs may be present. This is also a good view for color Doppler evaluation of the mitral insufficiency. The apical four-chamber view demonstrates well the size of the primum atrial septal defect and the size of the inlet ventricular septal defect. This view is good for evaluating any abnormal chordal attachments, especially chordal attachments that may be straddling into the opposite ventricle. Again, in this view, we can evaluate the relative sizes of the ventricles looking for unbalanced forms of AV septal defects. And again, Doppler and color flow assessment will be important of the AV valve regurgitation. With the subcostal four-chamber view, the entire span of the atrial septum can be visualized with good visualization of the primum atrial septal defect and evaluation for the presence of a secundum atrial septal defect. In some cases, the atrial septum may be completely absent, resulting in a common atrium. With slightly more anterior angulation from the subcostal four-chamber view, the elongated left ventricular outflow tract can be visualized with the presence of the classic gooseneck deformity. In this view, both the atrial and ventricular shunts can be evaluated with color and continuous wave Doppler, and again, the presence of AV valve regurgitation can be assessed. The subcostal short-axis view is an excellent view to obtain an en face view of the common atrioventricular valve, and this is a useful view for evaluating the AV valve morphology as well as the chordal attachments. To obtain this view from a standard subcostal four-chamber view, the plane of sound is rotated 30 to 45 degrees clockwise, and this will obtain the en face view that's shown on this slide, which shows very nicely the 5 leaflets of this common AV valve. In the subcostal short-axis view, the AV valve morphology can be evaluated with the presence of either a single orifice or double orifice atrioventricular valve. With scanning down into the body of the ventricle, the attachments of the AV valve can be seen, with the attachments of the anterior bridging leaflet to the infundibular septum and attachments of the posterior leaflet to the inlet trabecular septum. The atrial and ventricular shunts can be visualized with color and continuous wave Doppler, and again, color flow assessment is performed of any regurgitation of the AV valve. With unbalanced AV septal defects, there's connection of the AV valve to predominantly one ventricle with hypoplasia of the other ventricle. This occurs in approximately 5 to 10% of AV septal defect, with the right ventricular dominant AV septal defect being more common. Often there's malalignment of the atrial and ventricular septae, and this type of defect requires a combination of views to judge the relative sizes of the ventricles. One needs to be aware of relying solely on ventricular volumes in deciding a 1 or 2 ventricular repair. This is because the AV valve imbalance may not correlate with the degree of ventricular hypoplasia. Also, the degree of right to left septal bowing may contribute to a smaller appearing left ventricle that may improve if the part were septated. For the remainder of this talk, I will go over several cases illustrating the spectrum of the anatomy of AV septal defects. The first case is that of a partial AV septal defect. In this parasternal short-axis view at the level of the ventricles, we can see the significant dilation of the right ventricle due to right ventricular volume overload. The function of the ventricles appears normal. This is the parasternal long-axis view, showing significant dilation of the right ventricle. We see that the left ventricular outflow tract appears widely patent. The mitral valve does appear mildly dysplastic, and the tips of the mitral leaflets are oriented more towards the ventricular septum than in a normal heart. This is an apical four-chamber view showing significant dilation of the right atrium and right ventricle. We can see the large primum atrial septal defect and the insertion of both AV valves onto the crest of the ventricular septum with no evidence of a ventricular level shunt. This is a subcostal four-chamber view demonstrating the atrial septum. We see the large primum atrial septal defect with no evidence of a defect in the region of the secundum atrial septum. This is a subcostal short-axis view showing an en face view of the mitral valve. This nicely demonstrates the cleft in the anterior mitral leaflet. Going back to our subcostal four-chamber view, looking at the atrial septum, we can see the large left-to-right shunt across the large primum atrial septal defect. With the addition of color flow to our apical four-chamber view, we can see the exuberant pulmonary venous return due to the significant left-to-right shunt. We also see a mild degree of mitral valve insufficiency due to the cleft in the anterior leaflet of the mitral valve. Moving the color box over towards the right ventricle, we see a mild to moderate degree of tricuspid valve insufficiency, and again can see the significant left-to-right shunting at the level of the primum atrial septal defect. The next case is a patient with a complete AV septal defect. We start with a parasternal short-axis view at the level of the ventricles. We can see normal ventricular function, and there's a relatively equal size of the left ventricle and right ventricle. This is a parasternal long-axis view of this patient. The striking feature in this patient is the left ventricular outflow tract. We can see the elongation of the left ventricular outflow tract as well as some accessory AV valve tissue within the LVOT. So in this patient, it will be especially important to evaluate the LVOT for evidence of obstruction. This is a parasternal short-axis sweep, starting from the base of the heart, moving down into the ventricles. As we go through this sweep, we can see the large primum atrial septal defect, the common atrioventricular valve with relatively equal commitment to both ventricles, and then the large inlet ventricular septal defect and no evidence of any additional VSDs. This clip shows the classic apical four-chamber appearance of a complete AV septal defect. We see the large primum atrial septal defect, the common AV valve, which is committed to both ventricles, and the large inlet VSD. Both ventricles are relatively balanced in size with normal ventricular function. With more anterior angulation from the apical four-chamber view, we can examine the left ventricular outflow tract. Again, this view demonstrates the presence of some AV valve tissue in the LVOT. With Doppler interrogation, we will need to look for any evidence of obstruction in the left ventricular outflow tract. This is a subcostal four-chamber view. Focusing on the atrial septum, we can see the large primum atrial septal defect and no evidence of a secundum atrial septal defect. This is a subcostal short-axis view showing our en face view of the common atrioventricular valve. We can see the anterior bridging leaflet inserting into the conal portion of the ventricular septum, making this a Rosselli type A common AV valve. Again, we can see the relatively equal commitment of the common AV valve to both ventricles and a balanced size of both ventricles. Going back to our subcostal four-chamber view, we can see the large primum atrial septal defect with a large left-to-right shunt. We are also beginning to see a mild degree of regurgitation through the left component of the common AV valve. This is an apical four-chamber color flow image. This demonstrates very exuberant pulmonary venous return into the left atrium and left ventricle due to the large left-to-right shunt in this patient. Again, we can see a mild degree of regurgitation coming from the left component of the common AV valve. With anterior angulation from the apical four-chamber view, we can evaluate the flow out the left ventricular outflow tract. In this case, the flow appears low velocity with no evidence of left ventricular outflow tract obstruction. This apical four-chamber color flow view shows the shunting at the atrial level as well as shunting in the region of the inlet ventricular septum. This is a parasternal long-axis view with color flow imaging of the left ventricular outflow tract, again demonstrating that in spite of the presence of some accessory AV valve tissue in the left ventricular outflow tract, there is no evidence of obstruction. This is a parasternal long-axis color flow image showing the mild degree of left-sided AV valve regurgitation. This is a parasternal short-axis sweep from the base of the heart down into the ventricles. As we go through this sweep, we can see the large left-to-right shunt across the primum atrial septal defect and across the inlet ventricular septal defect. The next images are taken postoperatively of the same patient with complete AV septal defect that we have just been viewing. This is a parasternal short-axis view at the level of the ventricles, again showing equal ventricular sizes and normal ventricular function. There's no evidence of pericardial effusion in this postoperative patient. This is a parasternal long-axis view. After repair of complete AV septal defect, we can see a dysplastic appearing mitral valve. Part of the appearance of this valve is due to sutures and pledgets that have been used to reconstruct the valve. The left ventricular outflow tract otherwise appears widely patent. This is the parasternal long axis view, zooming in on the mitral valve. Again, we can see the dysplastic appearance of the mitral valve after it has been reconstructed. This is an apical four-chamber view after repair of complete AV canal defect. We can see the patch, which is closing the primum atrial septal defect and the inlet VSD, and we can see the reconstructed mitral valve. With addition of color flow to our apical four-chamber view, we can see that there remains significant mitral valve insufficiency through the reconstructed mitral valve, largely through the cleft in the anterior mitral leaflet. In this case, this is resulting in severe mitral valve insufficiency. Moving our color box more towards the right ventricle from the apical four-chamber view, we can see a small residual ventricular septal defect at the inferior margin of the VSD patch, and we can see a mild to moderate degree of residual tricuspid valve insufficiency. Doppler interrogation of the tricuspid valve insufficiency reveals a mildly elevated right ventricular pressure with a predicted right ventricular pressure of 34 millimeters mercury plus the right atrial pressure. Another color flow image from apical four-chamber shows the significant residual insufficiency of both the tricuspid and the reconstructed mitral valves. With anterior angulation from our apical four-chamber view, we can see two small residual ventricular septal defects at the superior and inferior patch margins. We can also see the unobstructed flow out the left ventricular outflow tract. This is the parasternal short axis view at the base of the heart, again demonstrating the small residual VSD patch leak. And back to the parasternal long axis view with color flow imaging, we again see the severe residual mitral valve insufficiency through the anterior mitral valve cleft, and again see the unobstructed blood flow out the left ventricular outflow tract. Next is an example of a patient whose status post-surgical repair of a partial AV septal defect in a patient who also had a double orifice mitral valve. We start with a parasternal long axis view showing a relatively unusual appearance of the mitral valve. From parasternal long axis, as we angulate towards the right ventricular outflow view, we're seeing this small accessory opening in the mitral valve. This is a parasternal short axis sweep starting from the base of the heart into the ventricles. As we examine the mitral valve, we can see a dominant orifice that also has a cleft in the anterior mitral leaflet. To the left of that, there's a smaller accessory orifice. This is a zoomed view from parasternal short axis at the level of the ventricles. Again, we see this larger dominant orifice of the mitral valve that also has the cleft and the smaller accessory orifice. In this case, the cleft was left open due to a concern of creating mitral stenosis at the initial time of operation. This is an apical four-chamber view. In this view, we can see the patch closing the primum atrial septal defect, and we can also see the somewhat unusual appearance of the double orifice mitral valve. With addition of color flow imaging, we see a moderate to severe degree of mitral insufficiency through the anterior mitral leaflet cleft. This is a parasternal long axis view, again demonstrating the significant mitral regurgitation through the cleft in the mitral valve. From this parasternal short axis color compare view, we can see the double orifice mitral valve and the jet of mitral insufficiency originating from the anterior mitral leaflet cleft. The next case is a patient with a transitional AV septal defect. In this case, we start with an apical four-chamber view. We can see that there's a relatively small primum atrial septal defect. There's a fair amount of chordal and AV valve tissue attachments to the crest of the ventricular septum, and in this view it is difficult to determine if there is a ventricular septal defect present. Angulating anteriorly into an apical five-chamber view, we can see that the left ventricular outflow tract appears widely patent. We do see some of the accessory AV valve tissue, which is typical of many of these patients. This is an apical five-chamber view, color compared zoomed view looking in the region of the left ventricular outflow tract. In this region, in spite of this AV valve tissue, which is inserting onto the ventricular septum, we can see a left-to-right shunt across a VSD. With continuous wave Doppler interrogation of this VSD shunt, we see that it is restrictive with a gradient of 62 millimeters mercury between the left ventricle and right ventricle. This is a parasternal short axis color compare zoomed view looking at the mitral valve. We see the cleft in the anterior mitral valve leaflet, as well as some insufficiency originating from this. We also see the left-to-right shunt across the restrictive VSD in this view. Next is a patient with a left ventricular dominant, unbalanced AV septal defect. This is a parasternal short axis view at the level of the ventricles. In this case, we can see the dominant left ventricle with normal ventricular function. In this view, we see very little in the way of a cavity to the right ventricle, suggesting significant right ventricular hypoplasia. This is a parasternal long axis view showing the common AV valve committed predominantly to the left ventricle. The aortic valve arises from the left ventricle, and in this case, there's no evidence of left ventricular outflow tract obstruction. The AV valve does appear somewhat redundant and dysplastic in this view. From a parasternal long axis view, as we angle into a right ventricular outflow tract view, we see that the pulmonary valve appears hypoplastic. There's also hypoplasia of the main pulmonary artery. This is a parasternal short axis view at the level of the base of the heart. We see a mildly dilated aortic valve. There's moderate hypoplasia of the pulmonary valve annulus. We also see hypoplasia of the main pulmonary artery and of the branch pulmonary arteries. This is a parasternal short axis view sweeping from the base of the heart into the ventricles. As we sweep down into the ventricles, we can see the common AV valve committed primarily to this dominant left ventricle, and we see severe hypoplasia of the right ventricle. This is an apical four-chamber view showing almost complete absence of the atrial septum, resulting in a common atrium. We see the common atrioventricular valve with its predominant commitment to the dominant left ventricle, and we can see the severely hypoplastic right ventricle. From an apical four-chamber view with anterior angulation, we see the connection of the aortic valve with the left ventricle. There's no evidence of left ventricular outflow tract obstruction in this view. This is a subcostal four-chamber view showing the essentially common atrium as well as the commitment of this common AV valve with the dominant left ventricle. This is a subcostal short axis view showing nicely the morphology of this common atrioventricular valve. We can see that this valve is committed predominantly to the left ventricle with very little commitment to the hypoplastic right ventricle. We can also see the origin of the aortic valve from the left ventricle. With slightly more anterior angulation, we can view the left ventricular outflow tract. We can see the AV valve tissue in the region of the left ventricular outflow tract, and again, it will be important in this case to use color flow and continuous wave Doppler to assess the left ventricular outflow. As we add color flow imaging now, we can see that the flow from the left ventricle is low velocity with no evidence of left ventricular outflow tract obstruction. In this view, we can also see the origin of a patent ductus arteriosus from the underside of the aortic arch, supplying flow to the pulmonary arteries. This is an apical four-chamber view with color flow imaging demonstrating the insufficiency from the common atrioventricular valve. We can see three discrete jets of AV valve insufficiency. With anterior angulation from our apical four-chamber view and with addition of color flow, we can see the low velocity, non-obstructed blood flow across the left ventricular outflow tract. There's a very mild degree of aortic valve insufficiency that can be visualized. With still further anterior angulation, we can see blood flow across the right ventricular outflow tract and across the hypoplastic pulmonary valve. In this setting of a large patent ductus arteriosus, this blood flow appears low velocity. This is the peristernal long axis view showing a moderate degree of insufficiency of the common atrioventricular valve. We can also see the mild degree of aortic valve insufficiency. This is the peristernal long axis view with color flow imaging focusing on the left ventricular outflow tract, again demonstrating no significant obstruction and only mild aortic valve insufficiency. This is the peristernal short axis view at the base of the heart, demonstrating flow from the hypoplastic right ventricle across the pulmonary valve and into the hypoplastic pulmonary artery confluence. The next case is an example of a right ventricular dominant unbalanced AV septal defect. We start with a peristernal short axis view at the level of the ventricles. We can see the dominant right ventricle with moderate hypoplasia of the left ventricle. We can also see the common atrioventricular valve committed predominantly to the dominant right ventricle. This is a peristernal long axis view demonstrating a moderate degree of hypoplasia of the left ventricle. The aortic valve appears relatively well developed, although mildly dysplastic, and we can see the AV valve tissue within the left ventricular outflow tract. This is a peristernal short axis view at the level of the base of the heart. We can see that this patient has a bicuspid aortic valve. We can also see evidence of a patent ductus arteriosus. This is a peristernal, slide 104 again. This is an apical four-chamber view demonstrating a complete AV canal defect with moderate hypoplasia of the left ventricle. There's a large primum atrial septal defect, a large inlet VSD, and we can see that the common AV valve is predominantly committed to the dominant right ventricle. With anterior angulation from our apical four-chamber view, we can demonstrate the left ventricular outflow tract. In this case, there does not appear to be any obstruction across the LVOT. This is a subcostal four-chamber view in the region of the inlet ventricular septum, as well as demonstrating the large primum atrial septal defect. In this subcostal short axis view, we can see the morphology of the common atrioventricular valve. Again, we can nicely demonstrate that this valve is committed predominantly to the right ventricle. This is the apical four-chamber view showing excessive pulmonary venous return due to the left-to-right shunting in this patient. This patient only has a minimal degree of insufficiency of the common AV valve. With anterior angulation, we can see the low-velocity blood flow across the left ventricular outflow tract with no evidence of obstruction. We can also see the left-to-right shunting at the level of the ventricular septal defect. This is a peristernal short axis view sweeping from the base of the heart down into the ventricles. This demonstrates the left-to-right shunting at both the atrial and ventricular levels. The peristernal short axis view at the base of the heart with the color box showing the pulmonary artery bifurcation. This patient does have a small patent ductus arteriosus with bidirectional shunting. This is a peristernal long axis view with color flow imaging demonstrating no evidence of left ventricular outflow tract obstruction. This is a suprasternal long axis image with color comparison demonstrating evidence of coarctation of the aorta, which is not unexpected in this patient with significant hypoplasia of the left ventricle. In summary, in terms of the preoperative evaluation by echocardiography of patients with AV septal defect, it is important to identify the defect and establish the diagnosis, to confirm flow through the defect with color flow Doppler imaging, measure the gradient across the VSD with continuous wave Doppler imaging, measure the size of the atrial septal defect and or ventricular septal defect, assess the atrioventricular valve morphology, commitment of the valve and attachments, measure the relative sizes of the ventricles, estimate the right ventricular pressure, and evaluate the left ventricular outflow tract. It is also important to look for any other associated anomalies. In the early postoperative period, it's important to evaluate the ventricular function, examine the ventricular and atrial septum for leaks, look for pericardial effusion, check for AV valve regurgitation, check for AV valve stenosis that may have been surgically created, measure the right ventricular pressure, and evaluate the left ventricular outflow tract. And finally, late postoperatively, these patients should continue to be followed for evaluation of ventricular function, estimation of right ventricular pressure, evaluation of AV valve regurgitation or stenosis, and evaluation of the left ventricular outflow tract for obstruction. And I thank you for your attention during this lecture.